Good evening, folks.
Good evening.
Good to see you all.
As always, I will ask you to type a few words in the chat box. Particularly, we are interested in some information about yourself, where you are joining us from, where you are in the world. Are you in this country or joining us from abroad? And what settings you're working in. Are you in private practice? Are you working in the NHS? Are you working in a charity or school or college? There's so many different places that psychotherapists, psychologists can work nowadays. So if you just let us know a little bit about yourself. And always we're interested whether you've been to any SDS Thursdays before. We've been doing them for quite a while now, 2.5, something like that, years. So have you been to our Thursdays before? I can see some very familiar faces and want to welcome you. But I'm sure there are some people who didn't come before. So how did you hear about us? And whether you've done any SDS training events with us, and if you have, what they were. We today want to start a slightly new format of SDS Thursdays. I called it SDS Thursday Texts, sort of giving myself a broad field to play with, because if I'd say articles, it means that we always do articles, but we hope to discuss with you some publications, not only in magazines, but maybe on YouTube channel, maybe even some interesting Twitter discussions, which I know Paul is always following. So that's why we said texts in a broad sense. So we want sometimes bring up topics which are not necessarily directly linked to our training, even though when I look at the archive we've got, we practically covered it all. So no matter what we do, you maybe will be able to find an SDS training on the topic, but not necessarily immediately linked to our training, but linked to your practice and linked to something which is topical and people want to discuss. So like in that sort of scope, today we will be talking about a recent article about working with PTSD, and we know that you're always interested in everything relating to trauma and trauma treatments. So that's why we've chosen that particular topic today. So please carry on typing. I can see there are some messages, and thank you very much for them, but I can see there's many more of you in the room, so please carry on letting us know about yourselves, and also anything you want to suggest for SDS Thursday, for our format, maybe for topics, anything you think is relevant would be very much appreciated. Today, the format of the presentation will be, Paul will do a short PowerPoint presentation, will take you through the article. I will put the link to the article in the chat box, but I think you've received it in your email. So if you wanted to already, maybe have already read it. So after the presentation, I'll ask him a couple of questions and then we'll pass the virtual microphone to you. So please think about your questions, type them up in the chat box or put your hand up and ask them yourself. But it's very much an invitation for a discussion on this very important topic. So thank you very much, and I'll be very happy to welcome Paul Grantham and pass it to you, Paul, for your presentation. Please.
Okay, thanks very much, Julia. Can I know that you've not mentioned it, but can I just mention it? If Julia is sounding slightly hoarse at the moment, it's because she's on the tail end of COVID, and although she's tested negative, a few days ago she's still quite symptomatic. One of the effects being still a cough and a sore throat. So I just thought I'll mention that briefly. So folks, I wanted to take you, I don't know how many of you have seen this article or come across this article, but I thought it would be quite useful this evening to just take you through the main points of the article, but with a primary aim, to be honest with you, of using it as a springboard for discussion. Because I think that it raises a lot of very interesting points, some of which I suspect you may not necessarily fully agree with. Some I suspect you may well do, and I just really wanted to use it in that particular context. I'd probably also say, without stealing too much of my own thunder in advance here, I think it actually raises some issues which are not just specific to PTSD or to trauma. I think it actually raises some broader issues about, well, a whole variety of things, which I will open up as we actually go along. So let me first of all just share my screen, which I think is that one. Oh, no, it's that one. Right. So hopefully you can actually see that now. And so what I'm going to do, as I say, is just, I'm going to run through fairly quickly the actual summary of what the article says, maybe make at the end of that a couple of general points, and then sort of throw it open for questions, really. This is an article that's been published basically from Oxford University's Oxford Cognitive Therapy Centre, from David Clark and Anke Ehlers' team, who are probably the foremost, I guess, research centre on PTSD in the UK today. And indeed within CBT, the sort of Ehlers and Clark model is probably the most dominant model, probably over the last 20 odd years, in fact, in terms of providing a structure, in terms of making sense of PTSD and how to intervene. So they've got obviously a big research team and a big research background on both what PTSD is about and how to actually approach it from a CBT perspective. Let's just start off really by just broadly going over, if you're not familiar with it, the cognitive model of PTSD. Some of this may or may not be a surprise to you or new information to you, depending on your backgrounds. But basically, the cognitive model is that it's basically the meanings that people attach to a traumatic event, which tend to create difficulties for them, rather than the traumatic event per se. So, it's the fact that a traumatic event has occurred, and as a result of that, the meaning that I attach to that is, I'm the one to blame. I've caused this bad thing to happen, and I'm feeling very guilty or depressed or anxious or whatever. Or I might attach a meaning to it that life is highly unpredictable and very dangerous, and you've got to be looking over your shoulder all the time. And again, that tends to be the concern for people. So the cognitive model basically argues that the reasons for this primarily are that trauma memories are unprocessed or poorly elaborated, and they're not properly integrated. So for a whole variety of reasons, what's actually happened to the individual almost becomes a series of intrusive memories which are not really sort of updated by what's actually happened since. So, I might well have a memory where I'm utterly convinced I'm going to die. I might never see my children again. I'm an extraordinarily bad person that this has happened to, and so on and so forth. In some instances, of course, particularly with childhood memories, there are bigger gaps in there. But again, they're not integrated into what is called autobiographical memory. Autobiographical memory is, very briefly and bluntly, if you're not familiar with it, is the sort of narrative memory we have of ourselves, and that there is on the whole a sort of a knitted together sequence of events that we tend to have about ourselves, and the basic model within for PTSD from a cognitive perspective is that this very traumatic, very important event has not been integrated into people's memory, and that's one of the reasons why people have got ongoing problems with this. The other side to it, in terms of why people have got ongoing problems from this historical traumatic event, has to do with their use of what are called safety behaviors, which I'm not going to go into in detail today. If you are really interested in this and it doesn't mean a thing to you, basically come along to our introductory CBT course and we'll take you through it. But very briefly, what these are, they're things that we do to try and prevent the worst from happening. But actually, these things that we do to try and prevent the worst from happening actually make the problem worse. So 3 key ones here, which are not exhaustive, but are very commonly used by folks who suffer from PTSD, is thought suppression, about trying to suppress the memories, substance use, to try again and manage those memories and the feelings associated with them, and also rumination, which is most commonly both the preoccupation and the running through of the memory, typically repeatedly, almost in a problem-solving way. I repeatedly go over this in my head to find out if I could have made it any different, or if I could have created a different outcome, and so on and so forth. Okay, so the basic model argues that ongoing problems tend to be related to those particular strategies as well. So the broad model argues that there needs to be an individual case formulation, and that once this is actually completed with the client, the first step in the program is primarily, in most instances, to restart, if they've not already started, but to restart, for want of a better term, normal life activities as best as possible, and within the limitations that are around for the client, to at least begin to engage in social contact or try to increase it. So I think that typically what's occurring here for a lot of people following trauma is that they tend to reduce their activity levels and tend to socially withdraw. And we know from a whole range of other work that's around that when this tends to occur for people, it makes the problem far worse. So that's the sort of first step. The next point is about focusing in and zeroing in on the appraisals and meanings that the individual has attached to this particular event, everything from I'm going to die through to I've caused all this to happen, or it's always going to keep happening to me again in the future. So in a sense, that focus is cognitive in nature. The third step is what's basically described as being updating trauma memories. So very often individuals will have, as I say, either gaps in their memory, or alternatively will have inaccurate memories. And there's a variety of ways and strategies where this is actually being done during the course of therapy. Then looking for stimulus discrimination of triggers. So let me just say a little bit more about that if you're not familiar with the idea here. The assumption within the model is that the way that the trauma affects the individual now, in terms of interfering with their life or causing them to have distress, is not continuous. It is something which tends to go up and down according to primarily environmental triggers, but can be internal emotional ones as well. So one of the most common triggers that tends to be around, which people often associate with a trauma, are sensory triggers. So for example, particular smells, for instance. And what actually happens, of course, is that at the time of the trauma, that particular sensory experience was a trigger. was something which indicated that something bad was either going to occur or had just occurred. But obviously now that's not the case. But unfortunately, the individual is still behaving as if that trigger was actually occurring. So if I can give you a personal example of this with someone I worked with who was gang raped, and one of the sensory triggers for them in connection with their gang rape was that one of the individuals engaged in this ran a fish and chip shop, and she has a very strong sensory association with that, with the smell of fish and chips. So one of the effects now, not surprisingly, is that when she goes past a fish and chip shop, or certainly when I started working with her, when she went past a fish and chip shop, she would start thinking, oh my God, it's going to happen again. And she would start having other experiences associated with that, because she associated that past trigger with what was going to happen to her now. So that's commonly seen as being quite important before engaging in what's called a site visit. So quite a lot of the work that occurs within this model is actually visiting wherever possible the actual site where the trauma occurred. The next step really, which is again for many of you I guess will look quite familiar from a CBT perspective, is that we would then look at dropping safety behaviors. So safety behaviors, generally speaking, when they're playing a role in maintaining a problem, are not something in most instances that we would address early on in therapy. We would typically be looking for some degree of change for the individual before we start working with them in terms of encouraging them to drop those. And if you're sitting there thinking, well, why is that so important? It's for two reasons. Again, I won't elaborate this very much this evening, but basically because safety behaviors get in the way of discovering whether my beliefs are actually true or not. So they tend to support the ongoing negative beliefs that I've actually got. And secondly, as well, they work from a negative reinforcement perspective in terms of being quite addictive in terms of keeping unhelpful behaviors going. And then right at the end, we'll put all of that together with a therapy blueprint, including something on relapse prevention as well. So that's if you're interested in this, and you're not familiar with this sort of background, can I just say, please do go and have a look at the very least, our introductory CBT course, and we also have a specific module as well that looks at the basics of a CBT approach to working with PTSD. So why have they published this paper when they have, which has come out this month, I think, or was it last month, the end of last month? So it's very recent. It's difficult reading between the lines on the paper, but broadly speaking, they obviously something's led them to decide that they want to communicate this now, which is around what they see as the gap between clinical trial outcome research and routine clinical practice. So, for example, if you look at clinical trials using a CBT approach, this is probably one of those diagnostic problems where CBT gets some of its very best results. And you know, that 75% recovery rate, at least meeting certain criteria with regards to recovery, is pretty common within the clinical trials that are around on CBT for PTSD. But that at a clinical practice level, the outcome research where it's being evaluated is not producing results which are as good as that. So obviously the data where they have the most data tends to be from IAP services, simply because they are routinely evaluated, and there is a recovery rate of 40%, which, you know, is not bad, but it's certainly nothing like the sort of recovery rate that's occurring within clinical trials. So what they are arguing is that the reasons why these results are not as good is because in routine clinical practice, there is a tendency to ignore certain key parts of the treatment which are integral to the most effective cognitive therapy for PTSD. And these are the areas that they highlight as being basically more likely to be left out of therapy, and which they believe are integral components in the therapy in terms of getting those particular results. So first of all, a tendency not to work so much with trauma memories, and I'll come back to why they think that that's the case in a minute. Far, far fewer out of office sessions with clients, primarily for behavioral experiments. I'll again come back to that particular point in a minute, but they see this as being pretty crucial to getting good results. And that, not surprisingly, fits in with a greater tendency for there to be fewer site visits as part of therapy. Generally speaking, less exposure work, which is common and an important part of a cognitive approach to dealing with PTSD. And generally speaking, with clients who are presenting with multiple traumas or who have got significant social problems, generally speaking, the therapy work tends to be much less trauma focused. So that would raise the question of, well, what is it that's being focused on? So they don't specify this, but I'm going to guess it would be a focus, for example, on depression and low mood that's occurring for individuals, rather than looking at the specific trauma, or alternatively trying to address the social issues that are around for the individual. So that's what they suspect is the reason. And they then go on in the article to highlight what they see as being 10 misconceptions that are around about cognitive therapy, or CT, for PTSD. So I'm going to run through what their arguments are. I'm not going to comment on those at this particular point. I obviously have my own thoughts about these, but equally, I'm interested in what your thoughts are as well about these. So because we're going to be going through 10 separate identified misconceptions here, I'm trying to remember these for the end of this short presentation. It's probably going to be tricky. So do pop them in the chat box, basically, as you're going, as I'm going along. So if particular things cross your mind and you think to yourself, yeah, but what about such and such, or so and so, or is that really the case, or whatever, pop it in the chat box and we can pick it up afterwards. So number one, cognitive therapy PTSD is not suitable for complex or multiple traumas. And as they tend to do with practically all of these misconceptions, they tend to refer back to the research that's around. So their argument is if you look at the research that's used CT PTSD, a lot of this research is not actually about single episode trauma. You know, it's not just about, for example, battlefield trauma where someone has lost a limb or whatever. It also incorporates other types of trauma, which are often ongoing, such as childhood sexual abuse. And that there doesn't appear to be any major difference in outcomes between complex or multiple traumas using this approach and single episode traumas. The only difference tends to be that you do get slightly less symptom reduction. You do often have to address more frequently substance misuse before you start. And very often you tend to need to have an additional number of sessions in order to address it. But leaving that aside, the basic therapeutic process in the research is broadly speaking the same, and the results are broadly speaking similar. The other point that they want to make, which I think is an interesting point, is that if individuals have actually experienced more than one trauma in their life, very often you will actually find that there are linking themes in those traumas. So, you know, that belief, for example, that I have caused this to happen may well be a belief that crops up in more than one trauma. And for that particular reason, there is a certain validity and economy of time of addressing that particular theme that runs through a number of traumas, rather than thinking, oh my goodness, which trauma do I start off with working with here? And equally, when you move outside the trauma environment and you look at other types of negative belief that might be floating around in connection with other types of mental health problem that people have. If you take depression, for example, those sorts of beliefs also crop up in depression and in certain anxiety problems. So actually looking at a number of traumas, in inverted commas, in one go, may actually be quite useful, because you will find there may be only one or two single themes which run through all of these and which can be tackled at the same time. Secondly, is their argument that it's a misconception that stabilization always is needed before memory work. Now, they actually make a reference to this, about where this idea has come from, which I'll be absolutely honest, I've not mentioned here because I'd never actually heard of it. I assumed that that idea, or at least I've always been of the opinion that that idea that stabilization may be needed before memory work largely comes off the work that's been developed with dialectical behavior therapy. So I don't know how many of you are familiar with that, but the idea within DBT is that before you can very often work specifically with the trauma, individuals need to go through a stabilization process, really, where their skills for things like emotional management and emotional regulation need to be strengthened in order that they are strong enough to then go and do the trauma work. But their argument is that actually, although that might occur in some rare instances, it is not needed in the vast majority. And when they argue that when you actually look in the research at the dropout rates that are around, the dropout rates are not particularly higher with individuals who've gone through a stabilization process first versus those that haven't. Although they wouldn't wish to negate the fact that with everybody that we work with, a risk assessment needs to occur, first of all. But I think that they are primarily here thinking about suicidal and self-harm risk rather than anything else. And that there are some individuals who may have dissociative problems as well, which I'm going to come on to as a separate issue in a minute. But their argument would be that maybe if individuals have some degree of problem with dissociation, you may need to do some trigger discrimination work, first of all, put into plain language. You may need to do some work with the client to help them spot what the early warning signs are or triggers that they might lead to dissociation, and also provide them with some fairly basic, and I probably suggest fairly briefly taught as well, skills in which to handle that. And they also make the point that they do accept that verbal retelling of the trauma may be not always appropriate for everybody, because some people may find that quite difficult to manage. And that if that's the case, it doesn't mean to say that we don't do anything. It just simply means that we may be encouraging the person to write that down rather than verbally tell us. But apart from that, there's nothing more is required, their argument is. Thirdly, the idea that talking about trauma memories is re-traumatizing. I think the first point they want to make, and I'm quite happy to come back on this at a later stage because I do think it's an interesting question. Their basic argument is, yes, individual clients may find talking about trauma memories distressing, and they may get a small temporary symptom increase while they're doing it. but this is not the same as re-traumatizing the individual. And we'll come back to this point later on, but I think it's a broad sort of point that they're trying to make, that there is a distinction to be made between the discomfort of therapy, which they would probably argue is an integral part of all effective therapies, that it's going to create some degree of discomfort, and taking the lid off Pandora's box and re-traumatizing the client, which they would argue is not occurring here. And indeed, they point to research which indicates that there's really very little evidence of symptom deterioration during therapy when this is actually done. And actually, in instances where individuals are reliving part of the trauma in therapy, it can actually be a very positive experiential learning process. Because as I'm going through that particular process and I'm recalling the memories of that particular trauma with the associated meanings, which are things like, I am going to die, actually being able to do that in therapy, I can actually discover with the help of my therapist that I am still alive, that I am actually safe, that that particular meaning that I'm attaching to this, actually, I can now discover is not true. It's something which is unpleasant, but it hasn't destroyed me. Fourthly, the fourth misconception they highlight is that some traumas shouldn't be relived, and they particularly highlight things like people's concerns about looking at sexual assault, traumatic bereavements, or child traumas. And again, their argument is that there's little evidence in the research to indicate that this is something which is qualitatively different than other types of trauma that individuals might experience. What you might get is you might get bigger memory gaps, and particularly for childhood traumas, but that actually those can be directly addressed within therapy. So, for example, when working with children, or even with adolescents and adults, where the memory of the trauma in childhood is very fragmented indeed, the therapist can give direct corrective information. You are alive. You are breathing. Get up and move around. Let's see whether you can actually move or whether you're glued to the spot, and so on and so forth. And also, obviously, cognitive appraisals that children very commonly make in connection with trauma, which is that they've caused this to happen and they're to blame. So their argument is that, in a sense, although trauma of all kinds is inevitably bad, the meanings aren't. And the meanings are something which are manageable and dealable with and changeable within therapy. Number 5, cognitive therapy for PTSD is a talking therapy. PTSD is not the first problem which CBT therapists would say this about, but I think they wanted to make a particular point about it in connection, obviously, with trauma and PTSD, which is they want to emphasize the fact that CBT is a doing therapy. It is not just a therapy where you sit in a room with your therapist and you talk about the trauma. So there's a lot of work that goes on in this sort of program, which is conducted out of office and which is also conducted not necessarily with a great deal of talking. So a lot of behavioral experiments are conducted. The use of behavioral experiments around the idea of conducting surveys. Site visits are seen as extremely important in this particular therapy. But their argument is that unfortunately these are often not used, and it's one of the reasons why the therapy is not as effective. Equally, the argument would be that because trauma affects the whole body, it means that there needs to be memory updating for the body as well as cognitively and emotionally. So just to give you an illustration of this, which I've sort of already touched on really, is that if I have a particular belief that I can't move, I'm glued to the spot in some particular way. Actually asking the client to get up, to walk around, to recognize the fact that they're walking around, to even say to themselves and the therapist, I can move my legs and I can walk around, is part of that corrective experience for the individual. Number 6, PTSD can't be treated remotely. You can guess what the background is to this, which is that basically a lot of the PTSD work was being done in the room before the pandemic, and then everything went and became remote during the pandemic. And what they found was that a lot of folks, a lot of therapists were not willing to do the therapy basically through a screen because they felt it was too dangerous. And they go into quite a lot of detail here about how the vast majority of the work can still be done remotely. So trigger discrimination, for example, exposure to the things that tend to trigger off certain reactions can be done remotely using audio and video files. Behavioral experiments can be conducted over the phone. So you might not be able to, for example, go out on site with the client yourself, but you can certainly be with the client by basically bringing the phone with you, or alternatively, it can be done totally virtually by using something like Google View. Disassociation rules out work on trauma memories. So I think one of the issues that's around here, which they are a bit concerned about, is that as soon as the term disassociation occurs, or people are seen to disassociate during therapy, a lot of people see that in very absolute terms. They tend to associate disassociation with things like people spending the whole morning going about activities and having no recollection of them afterwards. And although that does occur in extreme dissociative states, the vast majority of dissociation that might be occurring for people generally, I think, with PTSD, but specifically with regards to during therapy, is a lot milder and a lot shorter than that. So their argument is that if individuals show some degree of evidence of that, or they look at times like they might begin to glaze over, or they say, you know, while I'm talking about this, it feels like it's not me that this actually happened to. In other words, these relatively mild dissociative states, which nonetheless can still be scary, obviously, for the client, then again, you may need to use some strategies initially for dealing with this, or during site visits, again, with some trigger discrimination, but it doesn't mean that the therapy should stop. And there are other adaptations that they suggest as well. So, for example, if there's a reliving of the trauma that's actually occurring in terms of recounting the narrative of it, sometimes individuals need to do that with their eyes open rather than shut, because it's too scary to do it shut, or to do it moving around rather than sitting down. So long periods of dissociation are rare, and those may require preventative strategies first, but the suggestion is that this is a small minority of the people who do disassociate and who have PTSD problems. Number 8, which I won't say anything about it. I'll just mention it as it stands, really, which is that number 8 misconception is PTSD is about anxiety and fear. And the point that they actually want to make is the full range of emotions can be associated with PTSD. Anger, irritability, depression, and so on and so forth. And in fact, if you look at research surveys of folks who suffer from PTSD, only around half of the emotional reactions that are actually reported are anxiety-based. And that actually is a whole range of other negative experiences that people actually have. And I'm quite happy to come back to this particular point later on. Number 9, exposure needs to be graded. I think what they're trying to do here, to be honest with you, is to contrast their work with Edna Foy's work, which tends to be much more purely exposure based. But their argument is that if you focus on behavioral experiments rather than exposure, then actually you don't need to spread this over a long number of sessions. You don't need to be having an anxiety hierarchy, for example, which you slowly move through over a number of sessions. Although they do accept that even with behavioral experiments, therapist support and modeling may be needed. And can I just say, I am very pleased indeed to see a general trend that's occurred in recent years towards the acceptance, for a whole variety of reasons, incidentally, that therapists should frequently be accompanying their clients during behavioral experiments. But again, they recognize that memory updating and trigger discrimination may be required first. Number 10, in terms of misconceptions, is that cognitive therapy, PTSD, is protocolized, which, can I just say, I did look up because I've never come across this term before. I know what they mean by it, but I thought, gosh, that's really interesting. That's a new word, but they've obviously made it up as far as I can see. It obviously means that it's not conducted according to a rigid protocol, basically, of doing things in exact order, i.e. session 1 and 2 you do this, session 3 to 5 you do this, and so on and so forth. So they say it's a misconception that CT PTSD is protocolized and is inflexible, and that it's not based on a session by session protocol, and that this is the reason why an individual formulation is so crucial before you begin work. We can come back to this issue later on if you're interested in it, because it's an issue that I'm quite interested in, which is about the juxtaposition of individual formulation with the idea of being true to the model that's being used. Because obviously being true to the model tends on the whole to lend itself to using much more of a set protocol. So I'm quite happy to deal with that. But they want to just make clear here that, you know, this is not like, for example, the David Clark model on panic, which is much more prescribed in terms of what you do in groups of sessions. So yeah, their key practice points that they want to sort of draw out from this are that therapists may have beliefs about trauma-focused treatments that lead us to hold back from delivering potentially effective aspects of therapy. Recognizing, researching, and reflecting on testing out our beliefs is an important part of developing as a therapist. Several misconceptions about trauma-focused CBT are common, such as that it is unsuitable for certain types of trauma, cannot be delivered remotely, and is inflexible, but available research and clinical guidance doesn't support these misconceptions. And while sticking closely to evidence-based models of PTSD and in collaboration with their patients, therapists can deliver treatment techniques flexibly and creatively, adjusting their practice to address a wide range of PTSD memories, meanings, and behaviors. So there we have it, folks. I will stop my share at this point. Right, what are people's thoughts, or people pop things into the chat box, Julia?
Yes, there are quite a few questions and comments, but before we move to questions and comments, I just wanted to make a couple of points, because I've been putting links to SDS courses on PTSD in the chat box, and then I was asked about discounts a couple of times in private messages, and I thought, well, why not? So I've created substantial discounts for 2 courses, both presented by Dr. Andrew Beck. One has already taken place and now is online course. We call it instant access. So you purchase that course, you have access straight away, and you can do your 2-day PTSD training. And I've created a 40% off discount, but only for this group. So it will expire tonight. So if you want to book that course, follow the link. I've put it in the chat. I will copy it later on again. But it's in the chat box, so please check the chat box and book that course. It's a very good, and all the basics which Paul addressed briefly tonight are addressed in great detail with Andrew Beck, who is a great specialist in the area. And another course Andrew will be running for us live. It's also a 2-day course. He will be running it in November. And I also have created £100 discount for people in this group tonight for that course. It's a live course, but as always, you will have a recording. So if you can't attend both days or one of the days, you will have a recording to watch on that course. So have a look at the links in the chat box, or just go on our website, type in PTSD, and you will find the courses easily. And I also wanted just to say that I've seen lots of messages in the chat box from people who are here for the first time. I wanted to say welcome. I hope you enjoyed this format. And I also want to ask everyone whether you found the format for tonight useful. Please just put your comments in the chat box, because we will be obviously making decisions how to run Thursdays in the future. And now let's turn to the questions, but I want to ask the first question myself, Paul, if you don't mind, because obviously we worked with Anke Ehlers, and we all know of Dave Clark and their unit in Oxford. They are specialists in the field, and PTSD is something what they are dealing with on the daily basis. Is it realistic to expect the same results from therapists who are not necessarily working as part of a specialist team? And are all the 10 misconceptions applicable to those who are not part of the unit, which, you know, bread and butter is working with PTSD? You know what I'm asking?
Yeah, I do. And I think it's a very important question, actually, and I think it's one which arguably has applicability to a whole range of fields, which is, can the results that come out of a specialist unit on whatever really be the same as they are rolled out more widely? And my brief answer to that is I don't know of a field, not just within the psychotherapy area, but outside the psychotherapy area, where that's the case. So I think that undoubtedly the degree of efficacy is always likely to be less when you are a non-specialist and less experienced compared with a specialist experienced central unit. That I wouldn't dispute. However, I think that a lot of the issues that they're raising are not really, in my opinion, about the degree of technical expertise of the practitioner. I actually think a lot of the issues that they're raising, in my opinion, come from specific beliefs and anxieties that practitioners have, and the lack of confidence that they have. I think that what I suppose I'm trying to say is that I think that they raise a lot of valid points. I really do. I don't agree with all of them, but I think there's a lot of valid points. I think that there's a very interesting question about how we as therapists feel about our clients being uncomfortable in therapy, and the degree to which we feel comfortable about working with that. I'll just go on a brief rant about this because I think it is something that I feel quite strongly about, and it has broad applicability. I think for change to occur for any of us, unless it occurs in a sense without us being aware of it, but the vast majority of change that occurs as a result of decisions that we make in our lives usually brings us outside of our comfort zone. It requires us to be uncomfortable. Can I just point out that being uncomfortable is not the same as being unbearable. We don't want things to be unbearable for our clients, but I would argue quite strongly that for our clients to change, there has to be a sweet spot that we find whereby the client feels on the one hand safe, but on the other hand is feeling uncomfortable. And I think I know this is phrasing it in a slightly different way. What I think they're saying is that many therapists fail to find that sweet spot. They are too preoccupied with making clients feel safe. They're too anxious about what might happen. And I think they've got a good point to make on that. And I know that you know, I can think of many instances where actually if you don't go down that road, you actually drag out things for the client. And let's face it, our clients, when they see us, are already uncomfortable. So actually, if we're doing work with them that drags things out, which is not as effective as it might be, because we're not willing to incorporate certain elements within the therapy, then actually we are still causing prolonged distress or contributing to that. So I have some sympathy with what they're actually saying, really. And I think particularly, although they only mention it as one particular thing, I think generally speaking, my experience is that a lot of therapists are particularly reticent about using exposure with any type of anxiety-based problem, and that they very often draw the whole thing out over a longer period of time than is necessary, and it actually creates more discomfort for the client as a result. Yeah, I don't think you are going to get the same results as you're going to get at the University of Oxford in a specialist unit. But on the other hand, I think a lot of their points, not all, but a lot of their points, I think are worth reflecting on. And I think it's a very interesting issue, really, about whether at the end of the day, we end up projecting our own anxiety onto our clients. And that actually it's our anxiety about what we fear might happen, which actually we then attach to our clients. And I think it's to some degree what they're trying to refer to in those learning points at the end about examining our own beliefs, really. Yeah.
Thank you. I have several questions in the chat box from Professor Ghazala Rehman. I was wondering if you're happy to unmute yourself and choose which question you'd prefer to ask, because I think some of them may be already been answered. Are you happy with that? Thank you.
Yeah, I think I'm really interested and keen to know that combination of using the EMDR modalities integrated with CT, PTSD is a good idea.
Are you asking for my personal opinion, or my personal view is that if you are EMDR trained, and I would want to put that caveat in, but if you are EMDR trained, I personally would have a preference for starting with that. And the reason for it is that I think that it is potentially less distressing.
Yes.
However, rightly or wrongly, if you were to have someone here now, from the Oxford Cognitive Therapy Centre, I have a sneaking suspicion they would say, which I incidentally don't actually agree with, I'm just saying what I think they would say, is that actually EMDR is just imaginal exposure. And that's, if it's working, that's the reason why it's working. I'll be honest with you, I am not familiar with any comparative outcome research that has compared the two. So I don't know what happens in that instance. I can only offer a personal opinion.
Yeah, just wanted to add something. Like in my practice, what I'm doing is I'm making referrals for those trauma survivors to the therapist. So basically, I really found positive outcomes and heard from those clients after re-examination that they have really very positive outcomes if these modules are integrated with CT PTSD.
Right.
So,
okay.
Again, that was something I just wanted to.
Well, that genuinely sounds really interesting then. Yeah.
And if you allow me one more question, I wish to ask, what about the compassion fatigue? Those persons like who are like we're working with those trauma survivors, like they whole day you are talking with them and listening to them, talking to them, assessing them. So definitely at the end of the day, we end up with that as well. So supervision is one way of, but what about, is there any session?
I'm not aware, I'm personally not aware of any research that's looked at that specifically with PTSD. I have personally got quite a strong opinion on this, not just in this field, but in other fields of extreme distressing experiences where clients are sharing disturbing narratives, basically, which is, if I can put this into blunt language, the longer you get dipped in doggy doo, the more likely you are to come out smelling of it. And for that particular reason, I personally have quite strong views that if you're going to be working with extreme narratives of any kind, the same with murderers, for example. If you're working with these sorts of problems, if you're going to specialize, I think you ought to put a time limit on it. You know, I personally would say 4 or 5 years, although I plucked that figure out the air. Or alternatively, it should be blended with other work.
Yeah.
I'll be honest with you. And my experiences in what I'm about to say comes from a different environment. But everybody I have ever worked with who has given over the whole of their career to working with extreme experiences in clients is, in my opinion, not quite right.
Yeah.
They've been affected by it.
Yeah.
And, you know, I'm not saying don't work in these fields because we need to, but I think that this is leaving aside, can I say, the whole issue of supervision, of debriefing and whatever, which I think would be good practice anyway. Yeah. But I think the degree to which you immerse yourself in this, you need to give very careful thought to.
Yeah. Yeah. Thank you.
Thank you. I wanted to say that Andrew Beck, who will be running the course for us, actually what I'll do, I'll share my screen very quickly and show you where to find these courses and mention certain things. You can see it, Paul, yeah?
Yep.
Shared. Okay, fantastic. So let's just go into our main page. And I wanted to mention, so first of all, how to find the courses which are on special offer. You go on the front page, click special offers, and because they are on now, you will find the courses straight away. So Andrew Beck's course expiring in 0 days, it means at midnight. This is the discount, and another Andrew Beck's course on PTSD, 40% discount, again on the same page. So very easy to find in special offers. And if we go into the news and have a look at Free Thursdays calendar, what you'll notice is that Andrew Beck will be doing Free Thursday on complex trauma for us on the 13th of October. And because I have lots of questions in the chat box, which we will not be able to answer because it's already 8 o'clock, what I will do, I will copy them, send them to Paul and send them to Andrew. So instead of just talking about the course, we could answer some of your questions. So put that date, 13th of October, into your calendars. And because Andrew is specializing in this area, I think his opinion would be very valuable in answering your questions and discussing this article with him as well. So we will continue this conversation. Thank you very much for being with us tonight, and I hope to see you next week. Next week we have Professor Adi Giuseppe, the world specialist in anger, joining us from New York for SDS Thursday on anger. So please put it in your calendar, 7 o'clock next Thursday with Adi Giuseppe. Thank you very much. As always, you can put your thanks in the chat box, or you can unmute yourself and say your goodbyes. And we hope to see you next week. Bye-bye now.
Thank you so much.
Take care, folks. Look after yourselves.
Beautiful presentation.
Take
Thanks
care.
very much.
Thank you.
Thank you.
Bye.
Take care.
Bye.